just when I change slides. There is some background noise, but I'm trying my best to limit that. So as always, this information is confidential, privileged. We really shouldn't be distributing it, copying it, or sharing it outside of our department or county. So going on with case one, you guys can hear me okay with this headphones?
Yes, we can.
Okay. The first case is of a 6-year-old male that EMS had got a call on for shortness of breath. And at any point, if the medic is available to tell the story, I'd be happy to step aside, but they got called on a shortness of breath case. This was actually in Ridgefield. So if there's any CCFR, I believe, medics that were on this call, feel free to let us know if you'd like to talk about what you saw. So the patient was awake. His airway was open. He was labored in his respirations. He was pale, cool, and dry in appearance, and there were no signs of bleeding. Fire was able to get vital signs prior to transport agency's arrival. His heart rate was 122. His blood pressure was 142/58. His respiratory rate was 30, and his SpO2 was recorded at 92%. And at that time, that was room air, from my understanding. He was approximately 13.2 kilos based off of, I believe, his mom's recollection. Past medical history included cerebral palsy, epilepsy diagnosis with anti-epileptic meds, and then he also had an ASD, atrial septal defect, and a VSD, ventricular septal defect. The meds that were reported for him included baclofen, gabapentin, Keppra, lansoprazole, Topamax, and Senna. Really nothing. When I look at this list, I kind of think of, oh, he's on a seizure med and he's got some neuro problems with that gabapentin and baclofen potentially. The Topamax, I think maybe migraine history. The history of the present illness was that this kid's been sick for 1 day. He started 1 day prior, and then he started. Actually, I think it was 1 day. I ended up speaking to this mom later, so she clarified, got sick that day, and then it wasn't until he started having nausea, vomiting, and shortness of breath that she contacted 911. He was admitted previously to the ICU and required intubation during his last illness presentation. They get this call at 7:03 in the evening. I realize I jumped too quickly. Anybody have any questions on the first one? The first slide? If not, moving forward, they documented his GCS of 10, and with his past medical history of having cerebral palsy, it's important to know what his baseline is. So they did indicate that he wasn't as responsive as usual. So GCI 10 was a little off of baseline. They documented that he's developmentally impaired, he's nonverbal at baseline. They documented some physical exam findings of dry pool. There was accessory muscle use, retractions, bronchi, coughing, and some congestion. At 1 minute, they got a blood glucose, which was normal, and an IV was placed. At 2 minutes, they noted that his SATs were stable, SpO2 of 93. And at 9 minutes, they get some more vital signs, noting that his respirations were 29, his end tidal was 41. At 11 minutes, they noted that his heart rate was 135, no blood pressure, but a respiratory rate of 13, which is notable given that he was breathing twice as fast just a few minutes earlier. SpO2 of 94 and end tidal of 53. So we don't have an end tidal initial, but we're seeing that from the last one, it's starting to rise. At 14 minutes, his heart rate's 119, blood pressure 118/87, respirators of 19. SATs are still at 99, or actually higher than they were. So SATs are improved, but his end tidal is still elevated at 52. At 19 minutes, they get another set of vital signs similar to previous. And at 26 minutes, they get another set of vital signs, which are similar for all intents and purposes. They started transport at 28 minutes. He was on a 4-liter nasal cannula, and they noted that he started to become more somnolent. His respiratory effort was declining, and they were concerned about needing to intubate this kid. So they'd already left. They had left the scene, so they had asked for an AMR supervisor to rendezvous for a third rider. the information that I was told was that the medic had told the mother who requested to go to Dornbecker that they really felt that she was going to be an impending respiratory arrest needing intubation, and asked if she wanted him to potentially go to the closest hospital, being Legacy Sandy Creek. And the mother, who I agree, when I spoke with her, is very medically competent, very astute with this child's past medical history and complexity, knowing that he always gets transferred to Dornbecker. And as long as we were able to stabilize the kid en route, that she felt that she really was adamant that they would like to go to Dornbecker first. So the mother also told the medic that he is a very difficult intubation, that normally anesthesia struggles a little bit with him, that he has congenital anomalies to his airway. And she couldn't describe, she said it wasn't laryngotracheal malacia, but some other congenital anomaly to his airway, making him a difficult intubation. But she was adamant that if possible, if we were able to stabilize, to continue to Dornbecker. At 29 minutes, they get a vital sign of 125, 117/89, respiratory of 10, SpO2 of 99, and tidal of 52. At this point, at the 38-minute mark, it was felt that this child was nearing impending respiratory arrest. So RSI was, I think that might be Alice.
Checking up DJ and Sean.
DJ and Sean, perfect. So I'm at 38 minutes as you guys are headed to intubating this kid, if you'd like to. But the only thing is, where you're at, the radio background noise obscures your voice.
Okay. So you said you're about 38 minutes into the call, so we already started transporting.
And the other things I explained that you had discussed with the mother about potentially the decision to go to Legacy, and she was adamant that she really wanted him to go to Dornbecker, and that she had shared that he is a potentially difficult airway.
Oh, so we are on the 6-year-old with cerebral palsy. That call correct?
Yes.
Okay.
Yes.
Okay. So let me think. So I had picked up the supervisor, and we were on our way to OHSU during this time. And this child, I had a conversation with the mother about diverting to a close hospital, so Legacy being the closest hospital to where we were at. And she said that she didn't want to go there, and I told her that by diverting from the closest hospital where we could have some airway management, that it would mean most likely that this kid would decline, and that I would have to intubate this child, which she agreed that was okay process for us to do. And then I went and contacted my supervisor, who we just selected to pick him up on the way to OHSU, because it's just a quick stop off the exit there off of I-5, and it wasn't much of a delay. So we picked him up, and on the way to the hospital, the kid continued to decline a little bit. His GCS was initially like 10, was what we documented. It kind of decreased a bit more, like 9. He was starting to get more fatigue, so his respiratory rate started to decrease as well, and that's when we selected that we needed to intubate this kid, and we have the resources in hands now. So through the IV that the fire department had gone on, and we were able to give him ketamine and rocuronium is what we chose. So about 30 milligrams of ketamine and 15 milligrams of rocuronium. In this call, I knew that I wanted to try and do everything possible to avoid intubating this kid, just because the 6-year-old with cerebral palsy, this was going to be a tough field intubation. For sizing of the patient, I went off of size and not age, because I knew he was going to be undersized for everything. so he went off of the 30-pound weight, so 13.2 kilograms estimate. So we went off 30 pounds for PD stat. And so that with that, for his size, I ended up using a 4.0 ET tube with our PEDS bougie. Um, so gave him the ketamine, gave him the rocuronium. That went fine. Immediately went to lay him down, and I saw his airway, and I went, oh shoot, right. He had kind of with his cerebral palsy, his mouth was deformed a little bit. So his jaw looked smaller. He was anterior airway, as well as he had a couple of kind of big teeth, uh, minimizing the space that I had to intubate him already. Was able to look into his mouth with the VL. His Mallampati score was the worst. So like a 4. Yeah, class 4. And then when I was able to get so I wasn't able to look at anything besides his tongue when I looked down into his mouth. And then when I put the VL in to intubate him, um, I have a really poor field of view too. The grading that we use for ESO, he would have been a grade 3, so I can see only the posterior portion of the glottic opening. So I knew that I had to go more anterior with this airway as well. I had the Pete's bougie that worked after a little bit to finagle it into the right spot. I never had to pull it out, just kept having to readjust. If you haven't used the Pete's bougie, they're really thin and small, and so they kind of slip around a little bit. So it's hard to hold on to. My supervisor gave me a good coaching through it. We had good oxygen saturations the whole time, right? So once that was in, I was able to get the ET tube about a 4.0, about 16 centimeters at the teeth. And then able to bag him. And we were probably about, based on the notes, about 15 minutes out from the hospital at that point when we had intubated him. And we never needed to resedate him during the way in. So just kind of managed bagging him, keeping an eye on his vital signs, seeing if we needed to sedate him, but he ended up managing just fine with the intubation process after that. And that was maybe, it looks like 15 minutes left of that transport from what I noted from the documentation. So overall, that was a very difficult airway though. Yeah, probably one of the more challenging ones of my whole career, definitely.
Nice work. Definitely sounds like a challenge to do even in perfect settings. So anybody else have any comments about that?
No, I'd just say, you mentioned some of the things that helped you, like what, as you look back on what helped make this airway doable, are there other things that you'd pass on to other people if they're facing a similar situation?
Other things, let me try and think. So, yeah, knowing that first off, one with kids, especially respiratory, I want to do everything possible not to intubate this child. Of course, when we have to pull the trigger, we have to pull the trigger, right? So having myself prepared in advance for when that is going to he's going to decompensate, so we're prepared for it. For one, having like P-stat or the hand heavy, something that you can really look at so you can feel confident about like your equipment and where everything's at was super helpful. I think in the moment I didn't have, besides an eye gel ready to go, I actually think that I don't know if the eye gel was going to work on him. I don't know if it was going to fit in his mouth. That's how small his mouth was. And I think it was a 1.5 or a 2 for his back hip, and I was concerned that that wouldn't fit. So now my options are, I kind of have no choice but to get this tube. Fortunately, we had the nasal cannula going on him with 25, so we had really good oxygenation the whole time. And just emphasizing like practicing, right? Because like things that I wasn't aware of was that the Pete's bougie being so small and so hard to hold on to, that I had a little bit of lube from the tube on my hand or something. I just had a hard time initially trying to hold on to it. But once that was in with the bougie, the rest of it went perfectly fine. So if you can't get that though, then I wouldn't have been able to look into his mouth or have any other field of view. So it could have been a really bad situation, definitely.
Yeah,
And
no, I
what
agree.
oh God,
Go
yeah.
ahead. Go ahead, Jack.
No, I was just going to say what BJ and I have talked about is that, and I think that to stress that with everyone that is listening to this, if you feel that your pediatric airway skills is, there's no shame, there's no ego. If you feel that you are concerned about your ability to secure this kid's airway, even if the parent is adamant, I would say if you have hesitation that you would be able to go to the closest hospital, even if it isn't what the parent would want. Ultimately, this parent had stated that she knew it would take hours to get him transferred and that she wanted him to get to the definitive care if possible where they where they have experts in the field for him. But regardless of the situation, if you feel that you're not able to handle, you're not capable, not because of training, but because of comfort of managing that, there's no issue to go to the closest hospital for them to stabilize the patient. So fortunately, with the team that transported this patient, they felt like they would be able to adequately maintain the air or protect the airway or secure the airway. But I don't want anyone to feel like they have to be pushed to do something that they don't feel comfortable with.
No, I agree. I mean, and if I would go ahead, DJ.
I was just going to say off of that, yeah, part of the reason why I felt more comfortable making that transport was because I was having this very transparent conversation with her this entire time. And as parents of this child, they were so on top of his care and information about him that they like really good advocates for him, really knew everything. And that she was very confident that she really wanted to go there. And so I felt more comfortable having this conversation of, hey, I'm gonna have to intubate your kid, right? And she was comfortable with that, and so I knew it came from a sound mind because she knew it had happened before in the hospital. They had been intubated, so it sounds like they're just really on top of it, and I think that helped my process. If it was a family that didn't know medically any of that stuff, it wouldn't even been a question. I would have just gone to the closest hospital. So
Absolutely. And then
Yeah.
when you decided to use the smaller range for the ET tube, did you use just your PD stat, or did you kind of pull your ET tube and compare it to the pinky? I've heard that sometimes the size of the pinky can be helpful in determining the ET tube size.
No, I just went off of weight. Yeah, from looking at him, when we saw him, he was undersized for a 6-year-old for sure. He was in a like leg brace, so his legs were kind of sprawled to his sides, almost like kind of like a crab, like crab legs. And he was in a brace, so I just knew he had some other like deformity stuff going on. So I just went based off of weight and more of I mean, a little bit of fear with that too, right? I was more afraid of going for appropriate size for his age, and then just the anatomy of his airway being smaller with all of his other medical problems. I just elected to go down in size from the get-go.
And you felt like the bougie really, especially this difficult anatomy that you're looking at, really helped you in securing that airway, or
Oh,
you felt like
yeah, I don't think I would have been able to get that without this call in particular, without the bougie. Like I said, like his grading for his airway anatomy was so bad. There would have been a really bad, this could have been a very bad outcome, right? I think that if after that attempt, I predict that probably wouldn't have been able to get an eye gel in. If I did get an eye gel in, potentially break one of his teeth because the mouth opening is so small. So this could have easily turned into like a needle jet situation. And I obviously don't want to have that happen, and it would have been behind the 8 ball for that. But yeah, fortunately it worked out. And I've had a lot of field innovation, so there's some skill involved with manipulating that. But if it wasn't for that Pete's bougie in this call, for sure, I think it would have been a different situation entirely.
yeah.
No.
Unless anybody else has anything. Oh, go ahead.
No, I would just say, like, if I was in the back of the ambulance with this kid, like, I certainly wouldn't hesitate to divert to the closest hospital to have all of those resources there, to have, the fiber optics, the anesthesia backup. But I think this is a really good example of how, success and innovation is stacking up all of these things to get in your favor. Like the child was resuscitated before he was intubated. You were acting before the child decompensated. You know, they were showing signs that he was decompensating, but you acted before. You had positioning, you had apneic oxygenation, and then you had video, you had the bougie. And so it's all those micro skills that add up to success. So nice job with that.
Thanks, appreciate it. Yeah, and I 100% agree with that. Yeah, it was just kind of perfect situation. So where we set it up. So
There was no Pulsera because Dornbecker doesn't use it. And then the QA discussion, I thought serial vital signs reassessment, preparation, induction, successful first pass with difficult airway documentation, all the things that Dr. Mock has also mentioned. And I really didn't have any areas for suggestion for improvement unless anybody else has any questions or thoughts about adding or subtracting. Hearing nothing, I'll move forward. So the follow-up, fortunately, the mother was willing to take my call as we don't get follow-up from Dornbecker currently, unfortunately, but she said that in the emergency room, they made sure that the tube was in good placement. He had a seizure there, and they thought that it was probably related to the fever he developed. She stated that she was adamant that his meds were compliant, so it wasn't subtherapeutic. When he got admitted, he said that he was in Dornbecker's ER for less than 60 minutes. He went straight up to the PICU, the PICU, and they did viral testing for him. He was enterovirus positive. She stated that they trialed extubation on him on hospital day 4. They couldn't intubate him, and he went into cardiac arrest, so they did an emergent tracheostomy. And he was discharged on hospital day 24. When I talked to her a week and a half ago, she said that he's back in school, he's doing great, and she is so appreciative to the care that he received that day, but also other episodes that she's called for him, where she wasn't in Ridgefield. I think she was in Battleground previously, but either way, she's really, really happy that they were able to communicate with her and resuscitate her child. And she said to me, she goes, I was really impressed that he was able to get his airway too. So I thought it might be, we talked about the airway considerations already. So I thought this might be a good opportunity to talk a little bit about cerebral palsy. I do have a video, which I realize is probably not a great choice based off of location, as I don't have a computer to shut it off, but I'll skip through it. But cerebral palsy is a group of neurological disorders, and it usually is occurrent, prevalent or noticeable in infancy, but it can become more noticeable in early childhood, and it permanently affects the child's ability to move and coordinate. And what you see is what you get. It's not progressive. It's the leading cause of childhood disabilities in the United States, and usually it's identified by failure to meet milestones such as abnormal muscle tone, loss of selective control, difficulty with swallowing or feeding, but they also can have balance problems, hearing loss, vision loss, contracture deformities, and intellectual impairments, to name a few. There are risk factors that can occur pre, post, and peri pregnancy, and there are main types of cerebral palsy which are generally spastic, 70 to 80%. It's the most common form, but there also can be ataxic and dyskinetic, and then there's mixed type. There is also components of paralysis that can affect one limb as monoplegia or hemiplegia, as well as diplegia or quadriplegia. The management is usually multidisciplinary, so you need teamwork between speech therapy, physical therapy, occupational therapy. The kids are oftentimes on muscle relaxers such as Botox, baclofen, which this kid Dantrolene, Valium, and tizanidine, and that really is working to maximize function. And that diagnosis is generally clinical, although an MRI brain can be helpful. I think the underlying neurological disorder was a link that doesn't work here, but it was just a video of a neurologist, a peds neurologist, talking about this disorder. So for our regional protocol, pediatric patients, insufficient, well, I would say upper airway concerns, which we didn't have starter, didn't have croup, and we go down to didn't have anaphylaxis, so go on child deteriorates, ventilate with a bag valve mask, and if you cannot effectively ventilate with a BVM, perform intubation, which was expertly demonstrated in this presentation. So going on to aggressive airway management, including early intubation, is appropriate for the patient who does not respond to treatment or is rapidly deteriorating. I think were our major things. And then capnography is going to be huge. We'll have another case about capnography. Actually, we'll have two more cases about how important capnography can be in ensuring that you're not only ventilating, but you're adequately ventilating. Any questions or concerns about this case before moving on to the second case?
No, I just I went ahead and shared my screen because your slide of the protocol wasn't coming up. But no, the only other thing that I would say is, particularly with rocuronium as the paralytic, encourage, don't wait for signs like vital sign abnormalities or other thing. Just go ahead and provide the analgesia and the sedation at the predefined intervals. We've and that will be present in the protocol update going live on March 4th. But even under the current protocols, just if rocuronium is your paralytic, just remember, just provide the sedation before you have any signs that the patient needs it.
Dr. Gabois, you might try sharing your screen again. There you go.
Yeah, I just did. Yeah, just because it'll boot me off. Yeah. All right. So case 2 is a 5-year-old male. EMS got. I'll let DJ go ahead and talk about this one if you are ready for that.
Yeah, I can talk about it. So I'll start off with kind of came the call tapped out at and go on from there. So this was in Vancouver proper. This call tapped out initially as a auto versus pedestrian, and then when we were about a minute out, it had upgraded to the notes for the age of the patient, which was a 5-year-old male, and that there was CPR in progress. So we were first on scene, and I'm a field trainer cars, and this was in a parking lot of an apartment complex. So I'm in the back of the ambulance when we show up. I just kind of see through the little window, through the windshield is my field of view. That's all I have. So when we showed up, saw a bystander kind of kneeling over him. Uncertain for me if she was doing CPR or just kind of just touching him. I confirmed with my 2 partners. They don't believe that she was doing CPR. However, it could have been done prior to that by someone, right? So we show up, we grab our kits, we walk up to the scene. Bystanders immediately, everyone moved back like 50 feet and no one was talking to us. So that was kind of interesting. And then I noticed that when we're looking at him, it obviously presentation is very poor, right? The notes were that he had gotten his head run over. I mean, can't confirm it looked similar to that. I saw about 100 to 200 cc's of blood next to the left side of his head. He was supine with his head rotated to the left. When I first saw him, I thought that maybe he was going to have like an open skull fracture. He didn't. And then he kind of, tried to have a pain response, no response. So his GCS was 3. And then he had this kind of purposeful movement where he rotated his head forward and just kind of took an agonal breath that was very gurgly, full of blood, right? I went on the radio initially because because we were first there, and this was all very quickly, right? I just went ahead and upgraded to a cardiac arrest in the field. My reasoning for doing that was I didn't know who was responding. I knew we'd have 1 or 2 units responding. I didn't want them to be underprepared for the situation, being me saying that it wasn't cardiac arrest and then it still being extremely critical. And it was about to get really busy, so I didn't have time to kind of explain more details than that over the radio. So I just went ahead and said it was a cardiac arrest, and then just went to work. So we had to spend a lot of time just suctioning his airway because it was full of blood, and then was able to get a pulse ox and a pulse rate on him. So I put an addendum in my chart, but his initial heart rate was 76, and his SpO2 was 88%. So all we were able to do as far as a primary assessment of our ABCs, we were kind of stuck on airway. Suctioning, I got that initial pulse ox, SpO2, and then fire showed up right behind us. We immediately, the firefighter paramedic, I believe, just would, oh, we need to transport this kid, right? And we just kind of worked on packaging the kid. I pulled out a BVM, handed it off to the other EMT firefighter, bagged him. They got him on the gurney. I grabbed all the kids and we just kind of ran back to the rig and went. So actually, our on-scene time was 1 minute and 23 seconds. Probably about as long as it took for me to explain it all, but we just kind of scooped him and just started transporting. Now, location-wise, this is a big part of this, right? So location-wise, we're about Leaser and Mill Plain, that area. So location to Peace Health Southwest, we are, 2 blocks away from Peace Health Southwest, so 2-minute transport. But we're about 20 minutes. I know if we're about Leaser, we're about 20 minutes, code 3 to Emmanuel. So I had a gut instinct of, hey, this kid has a pulse. He's not dead, although, as Dr. Gabel and I discussed, he is peri-arrest. He's pretty critical. I went ahead and just kind of pulled the trigger and went, you know what, I want to take this kid to a level 1 hospital. They have ECMO, they have pediatric specialty trauma team there. I just want to go ahead and do that. And I'd rather get him there now as soon as possible versus delay definitive care and just go straight there. So we elected to go there during transport. Let's see. During transport, we were able to get an IO pretty quickly on him. Looks like maybe about 5 minutes later, we were able to get an iGel placed. Some of the complications that we were having at this point of the transport was logistically, we got the IO trying to get P set up on my phone, make sure we get the proper sizes. We were having problems suctioning him because he had a lot of blood kind of refilling his airway, and I wasn't sure at the time where it was coming from. It wasn't coming from his lungs, but it was filling up his oropharynx. So there's a lot of time spent suctioning by the firefighter who was on airway. We were having a hard time getting blood pressures on him. I think the first one, 144 or 106. So question the accuracy, of course. We weren't able to get manual blood pressures on him or automatic ones, and we were having difficulty with our SpO2 reading at this point. So we tried changing pulse oxes, pediatric pulse oxes, and it was, again, still having a hard time. I'm assuming just because of how shocky he was. But we're having pulses, brachial and carotid pulses at this time. I'm able to pull up P-stat. We were able to hand off a 2.0 iGel he was able to receive. And still had some problems with blood in his airway. And we were able to stick a French down the tube on the side of the iGel to help some of the suctioning. While that was going on, I elected to give him for RSI, we were going to do ketamine and succinylcholine for an approximate 50-pound male. I chose to use ketamine on him because potential catecholamine response, we weren't able to get a blood pressure on him. Any chance to try and help bring his blood pressure up, given the circumstances, I think etonidate would have just made it worse. So that's why I elected to go with ketamine. Handed those off to the firefighters, told them that we discussed doses as I was pulling out my ET tube. Again, I'm finding all this information out through PD stat. So I used a 5.5 cuffed. We gave the ketamine and noticed as we were checking pulses, because we had kind of continuously checked pulses at this point, his heart rate was kind of slowly starting to decline. I'm not sure if in the charts it kind of varies all over the place, but from Von Aram, he was kind of consistently in the 70s, and then after ketamine, his heart rate did kind of decline, and we noticed that we didn't have pulses anymore, and we started CPR. We had a quick discussion about treatment process. Very quick discussion about treatment process. Decided to give him succinylcholine anyways. Finished the intubation process since we were right there. And when I went to have the firefighter pull out the eye gel, we were using the French suction, which I'm in the airway seat. The suction's right there, and so the French catheter is attached to it. And I had not paid attention to where the big stick, the suction catheter, went. So when we pulled that eye gel out, that seal that had formed that was protecting his airway now was starting to kind of fill up with blood again. So when I went into with the VL to start the intubation process, I had to kind of lift his head up a little bit more to get his airway out from underneath the blood, which worked in the moment. However, all the blood in his mouth did kind of fog up the VL. But I was able to still see anatomy just through all the fog. And on this one, unfortunately, I wasn't able to find the pediatric bougie, so I just had to use the stylet that it came with. As far as initial pass goes, I kind of had a little bit of difficulty getting the ET tube in, and I needed to just readjust and hyperangulate the ET tube a little bit to curve it into where I want it to be. So I think that would technically be second pass. But this is all pretty quickly. Get it in, secure it, and pull it out, and we were getting good end tidal readings at that point, around 25, I believe. Yeah, I don't know, or maybe it improved later on to around 25. After the ET tube was placed, there was a lot of blood that needed to be suctioned out of the ET tube, which we use the French in order to do that. So now we were, I think, about halfway in transport at this point in time when he had arrested. So we're about 10 minutes from the hospital.
You guys he arrested at 10 minutes into the call. So, and then I think you said that it was a little bit off on the time of arrival to the hospital because of notified. So
yeah.
10 minutes from the initiation of contact with the patient.
Yeah. So, yeah, I think that I had talked to my partner about our destination time. So I think it was off by approximately 4 minutes there. So that last set of vitals, I think, did coincide with us arriving at the hospital. Usually we'll do a last set of vitals as we're pulling into the hospital just to kind of keep an accuracy of our care during the time that we have them. So the variability of it is so either 10 to 15 minutes from destination approximately is when he arrested on us, correct? So at that point, we had the ET tube placed. We were getting good compliance with the bagging. We had quickly discussed our HAP protocol, and if we wanted to do a bilateral chest decompression on this kid, and we elected not to. I think my choice was fear of size of needle for this 5-year-old. We have 14 and 10 gauge needles, and they're really long, as well as I didn't necessarily see any signs of trauma when it came to palpating him or anything, and I was getting good lung sounds as well. So I didn't notice anything indicating that I needed to. It seemed like most of his injuries were related to specifically head trauma, right? And of course, looking at over here, we were, trying to keep him in a neutral inline position as much as possible, not manipulating his head, but we didn't have a C-collar on or in backboard. I think I forgot to mention it, but we just kind of elected to just kind of emergently move him and start transporting, given the acuity of the patient. So after that, though, I think we're just on board with giving him epinephrine. I think traditional trauma arrest, we don't want to give epinephrine or it's not even a thought. And I was, after the call reflecting about it as an adult patient, I don't know if I would give epinephrine to an adult in a trauma whatsoever. But there's something about a kid that kind of changes your thought process, and the idea of doing nothing just kind of felt wrong. I don't know if that was for better or for worse, but we ended up giving him epinephrine anyways. And I will admit that the dosage was off. That was my fault. I didn't recheck PD stat. I just went off of 0.01 mg per kg and just went, oh, he's 50 pounds, it's 0.5, instead of just doing the quick conversion. I should have checked. My hands were bloody. I just didn't recheck the dosages there. So my doses for epi were off. So we got kind of a double dose twice. But we treat him essentially PEA arrest into the hospital. And that was kind of how the rest of his care went for the second half of that call. I think that was kind of, as far as complications go, I think I discussed most of it. I obviously C-collar secondary to the airway, however, is still important given the fact that he had a pretty big head injury. When I palpated his head, I palpated all around his head and couldn't feel any crepitation anywhere. It could have been an age thing, but I was kind of anticipating feeling crepitation. I didn't feel anything, as well as he had some blood coming from the back of his head, still while he was on the gurney. And I had no idea where it was coming from. So he had blood coming from the back of his head, I think just lower down towards the base of his neck, and from his mouth. And from the field point that I had no idea where it was coming from either of those spots. So it was kind of difficult to manage in general with that, for sure. And then, of course, we gave epi. Not sure if I would do that again or not. And the circumstances seemed to work out based on the conversation I had with Dr. Gavois. And then, of course, just the spinal immobilization stuff. But overall, we made decisions. We made them quickly. There was great communication with our end and the fire department. We had a good hot wash at the end of it, and I'm really proud of the work that we did on this call. It was really high acuity, and given the circumstances, we had a lot of successes and got him to our destination. And even though he arrested on us, we were able to still do some things and try and resuscitate him a little bit. So I think that's all I have as far as on this call goes. So yeah.
Dr. Mock, do you want to go first? Or do you want me to go? And then if you have anything else to add, what would you prefer?
Why don't you go ahead? Well, I'll go ahead and make my comments if you don't mind.
know.
So, no, I mean, the bottom line is, we're always going to support you when you're making tough calls in the moment. And this is a really tough case, and a really challenging case. My feedback, just two things. If you're, I'll just put our protocol up here. Regarding
Wait,
trauma
before
death.
you do, because
Sorry, go ahead.
before you do, sorry, go ahead, because it kicks me off, but I have it in but go ahead.
Okay. Sorry. So just, pediatric trauma entry, go to a manual or OHSU unless the closest hospital is necessary for airway control, vascular access, or arrest. I mean, this patient is peri-arrest. And so the bottom line, if I had to give you something, easy, actionable that you can use when you're facing a call like this, if you are closer to Peace Health with a peri-arrest kid, go to Peace Health. And especially when you're this close. What this kid needs is blood, may need a resuscitative thoracotomy, may need a decompressive craniotomy. Peace Health is capable of doing all of those things. ECMO is not a consideration in this kid unless you have some reversible cause, and those things are treating the reversible causes. And then the second thing I would say, just to clear up any confusion, epinephrine is not indicated in traumatic cardiac arrest. It doesn't matter if it's adult or pediatric, unless you have a suspicion. Please mute your microphone if you're not muted. unless you have a suspicion for a medical cause, epinephrine is not indicated in traumatic cardiac arrest.
Right. I can't mute that gentleman, but I hopefully he saw that.
That's a piece out.
Sounds better now. Good. No, and Dr. Gadbois, go ahead. Thanks for letting me jump in there.
Absolutely. Let me get back to. Yeah. No. We'll talk about destination as well. So about kind of reiterating what Dr. Mock already said, resuscitation, getting access on this kid early, identifying the airway issues, managing the cardiac arrest, scene time, really couldn't have asked for anything better than that. Serial vital, like 1 minute from transport agency's arrival. Serial vital signs on this patient, induction meds chosen, documentation. So I believe that the IO you used was a femoral. Is that correct, PJ?
Yeah, we went for a femoral IO initially. That was correct. I think it was mostly based off of logistically where we're at positionally in the ambulance with four providers. The easiest access point as quickly as possible would have been was going to be the femoral IO access at that point.
Yeah, and I only say, consider above the diaphragm if you think that this patient is an arrest, and with the initial presentation, you may want to consider humeral IO over femoral for that anticipated resuscitation. And then prepping for procedure, like you mentioned, you had an IGL section all secured, but once we moved to a different airway modality, being ready for that, that support adjuncts as well. I know that you claim full responsibility for the medication error, but you have a team of individuals on that scene. So anybody is also responsible for pulling up that information. And I know that you were very kind to not mention that hand tabby wasn't available. So it was the only reference available was the transporting medics device, which I think in hindsight, even if your hands are bloody, I'm not saying that you should touch your device, but to have somebody change and confirm that drop down box for you. And then, as we had mentioned with ACLS meds, although I think that that there's definitely different approaches to giving ACLS meds, as we're going to see that Randall's did give the kid epi. And I did a little bit of research on that, but the things that I was thinking about just listening to this case, and I don't know where my question, I guess, is where's the MPD stance on his heart rate being 637? Would that be indication to start CPR for I always think of it personally as like an infant with a 5-year-old. Where's our stance for heart rates that are that low? Should we initiate CPR?
I would not initiate CPR with a low heart rate and traumatic cardiac arrest. I mean, it's an open question whether CPR has any benefit at all in cardiac arrest. And, the priorities are, rapid scene time, which you did, rapid transport, and then HAT resuscitation. I think it's important that we keep trauma arrest simple. It's load, go, bed to chest, and get them to the trauma center.
Yeah. So I think that wasn't my feedback initially until I got the hospital follow-up. So I thought I'd ask that. And then the other thing is that, you had mentioned for, your rationale for not needling the kid's chest because it looked like isolated chest or isolated head trauma, breast sounds were clear. But the other things to consider, especially once CPR is initiated, is it difficult to ventilate this patient? Is there now chest trauma from the CPR? So using bag compliance, using lung sound, chest rise, tracheal deviation, because you have an added trauma complexity of your CPR. So CPR was initiated in the emergency room, straight to the operating room. Most of this is in the operating room. So right femoral central line was placed, an OG tube was placed, as well as an art line, and they did a point of care ultrasound, which was negative for the abdomen. I don't know if they looked at the heart, but they documented FAST was negative. He was in PEA with the initial rhythm check. Total of 4 additional doses of epi was given to him at 0.2 milligrams, and ROSC was achieved 16 minutes after the first pulse check. CPR was resumed because his blood pressure was, actually, this should be heart rate. Heart rate was less than 60. So they resumed CPR. They gave him another dose of epi at 0.2 milligrams, and then ROS was achieved at 1636. The meds that he received during his OR time was hypertonic saline, TXA, a unit of packed red blood cells, 2 units of cryoprecipitate, 3 units of FFP, and then he was also started on an epi and a norepi drip. CAT scan findings that are pertinent is that he had a subarachnoid hemorrhage, intraparenchymal hemorrhage of the brainstem and the pons, as well as a right frontal and bilateral parietal temporal bone fractures, as well as a fracture of his, I don't know if I'm going to pronounce it correctly, clivus. Patient currently felt to have a devastating brain injury that is non-surgical per the progress note. The fractures in his head or his skull was preventing increased intracranial pressure, and they noted that he had decorticate posturing, the stimuli affecting only the lower extremity. All other extremities were flaccid. Mark was so kind to get follow-up. I believe it was hospital day 20. They made him, before hospital day 20, they made him DNR and extubated him, and he had passed away on hospital day 20. So I thought that there were a lot of thoughts to consider regarding this process. This kid, the kid, had a horrible mechanism injury, and we really did a great combination of care between fire and AMR. But the first thing that came up was pediatric trauma diversion, needle decompression, and then if ACLS meds should be administered in trauma arrest. I talked to Dr. Timmons about this. Her comments were that if the kid is, any patient is peri-arrest, trauma arrest, that we should have peri-arrest as in addition to arrest. So in regards to pediatrics, the same goes for peri-arrest and cardiac arrest. If we think that the child is imminently going to have a cardiac arrest situation, she would want you guys to go to the closest appropriate hospital trauma center to help resuscitate this kid or patient. And then as for needle decompression, I asked her perspective, and she had said, be careful about administering or needling a kid in regards to with how deep you go, just be careful. And I think that the feedback I have for you guys, I did a little research. They state that the standard 14 and 16 gauge IV is 5 centimeters long, and that it's usually 2 times the length needed to be able to get to the appropriate location in a child under 13 years of age based off of CT imaging of the chest depth. So you can use your Broslow, and they looked at the Broslow tape colors to determine the depth, but it's dependent on the age and not sequentially increasing in depth. So I think that the recommendation that I would suggest is to pick up a 16 gauge needle for your little kids, and you're doing the same technique, second intercostal, mid-clavic, fourth intercostal, mid-axillary, and you're going to hit the rib and go over the rib as because your anatomy is going to be so much smaller. So the risk for injury to the nerve, the vessels under the ribs is high, and so is the risk of going too far. So you're really paying attention. You're slowly advancing the needle until you get the expelling of air, and then advancing the catheter, not the needle, to ensure that you're not going too deep, hitting structures that you're not aiming to access. I think if there's anything else in regards to needle decompression. I don't know if Dr. Mock, you have any of your own points for pediatric needle decompression?
No, I think you did a great summary.
Okay. And then as for ACLS meds and trauma arrest, there was a circulation article in 2019 that talked about it. And the points that so Dr. Timmons thought was she's not going to say no to ACLS meds, especially if there's a possibility of a medical cause a trauma arrest site. So she doesn't recommend a black and white approach to that. If there's concern that there was some type of medical condition that preceded, go ahead and do your medical resuscitation, even if the issue ended in a trauma incident. But with the article that I was reading, it was saying that, just like Dr. Mock had mentioned, it's early access to the patient, early transport to the patient, and not spending a lot of time on scene doing procedures. So as we saw in this particular case, they spent essentially 90 seconds on scene with this patient, did all the procedures en route. I will say that the article, it said that most of the patients will be in PEA because of, they listed all the potential causes of trauma arrest, including that you can have a trauma arrest for devastating intracranial injury leading to hemodynamic instability. I would say that my stance, which I don't know if that would be contradictory, is that if your patient's in VFib, that you would shock that because it's not perfusing. But I don't know if Dr. Mock, if you want them, vast majority will be PE arrest or asystole.
Yeah, if VFib response to shock, VFib is pretty rare in traumatic cardiac arrest. And
yes.
I would just, focus on the things that are proven to matter. These are, I don't need to tell you, these are super stressful calls. There were a lot of tough calls that were made in the moment on a call like this. Keep things as simple for yourself as possible. Go to the trauma center, use the HAP protocol, make it quick. Keep these calls. These are high stress. Keep them simple, fast, to the point.
Yep. And then I believe this is the same thing that Dr. Mock showed us already about with pediatric trauma resuscitation, diversion, and the under COPS receiving hospital diversion B. So I'm not going to go into that with you guys. And that is it. Last case that I have is a 72-year-old female that called for shortness of breath. DJ, can you do this, or are you on shift now?
No, I'm good. I'm on at 10:30. So
Okay.
Yeah, so this was I think the end of October. This was also
Right.
in Vancouver as well. So again, I'll start off with, I believe, from the transporting side, we were late. We were late to this call. I remember it being a foggy night. My trainees were up front with my EMT partner, and we had no GPS active on our CAD, so we had taken a wrong turn. This complex is kind of difficult to get into. There's like one good entrance to go into to get there. So we were probably 3 to 4 minutes on scene after the fire department. And that was error on our end, right? So cardiac arrest, I like to emphasize with my trainees that the first 8 minutes is the most important of any cardiac arrest. We want to get as much done as possible during that time to give them as much chance as possible. So this was a 72-year-old female who, it sounds like based on the notes, that she had a tracheostomy that had become dislodged, and then went into respiratory arrest and then cardiac arrest from there. So when we show up on scene, the fire department was resuscitating her in the kind of the living room area. Just by, it was actually kind of a small place, so the living room area that was also, you know, part of the front door opening. So we're kind of halfway out the door and halfway inside. So the information that I gotten from the fire department is that the family had tried to replace the tracheostomy tube by shoving it back in, and then that we were having difficulty managing the patient because it wasn't working. So an IGEL was in place. I believe a size 4 IGEL was in place. What I saw was they weren't able to really get any bagging done through it, and they were verbalizing that they were having a hard time trying to bag the patient during this. I believe the patient also had vomited, and there was also vomit in her mouth, as well as coming out her tracheostomy hole at this point when I had shown up on scene. So I elected to have my trainee go get the crite kit for me. While this was occurring, I asked for a 6.0 ET tube on a pair of shears. They had a 6.5. I felt like that was fine. So I cut a 6.5 ET tube down a little bit more manageable size and try to place it in the hole. It was able to go into the tracheostomy hole. It didn't feel like it was seating right. I tried inflating it, and they tried bagging through it, and it just wasn't working. So it just wasn't good placement. At that point in time, I wasn't 100% sure why, but I knew it wasn't working. So pull that out. While I was waiting for the crite kit, I cut a bougie down a little bit to make it more manageable. Tried putting the bougie into the tracheostomy hole. And I couldn't get it to advance. I was, again, having difficulty. And then I tried even just the rigid stylet, seeing if I could kind of hook it in there. I'm not sure what was going on. Didn't work. At that point, I just kind of felt inside and felt that there was some crepitation in her tracheal rings. It seemed like her tracheal rings believe I actually felt two. It felt like two tracheal rings had collapsed. So my partner had shown up with the crite kit. At this point, I'm not quite sure how far we were. Yeah, so 28. So
The surgical crite was documented 5 minutes after patient contact by transporting.
okay, yeah. So we were working. We were 5 minutes into this arrest window where that first 8 minutes is like the most important, right? So we were working on our airway management still. They handed me the crite kit. I was able to, you know, my thought process at the time was, well, this isn't going to be technically a crike. It's more of a tracheostomy. I just made a cut at the bottom of her tracheostomy hole to get the skin out of the way so I could see what I was doing. And then just elected to cut through the two broken, now I can see that there were two broken tracheal rings. I just cut through those, and then it was just perfect airway. She actually didn't appear to have aspirated since it had collapsed. It looked like it had protected her airway from any risk of aspiration. And then I was able to stick our Shiley down into there. I think they're 6.5 or 7 Shiley down into it. And then at that point, we got really great bag compliance. And I think we were able to get ROSC within one round of epinephrine after that. So patient management on scene, right, from when we had gotten ROSC to when we started packaging the patient, I think it was about 5 to 7 minutes in. Noticed that generally most cardiac arrests, when we first get them back, I have a kind of high indication of suspicion that their blood pressure is going to be soft, and a lot of these people require a pressor for blood pressure management at this point. So we went with norepinephrine and started that while we were packaging the patient up. That started off at about 4 micrograms, and by the time We were done using, or by the time we got to the hospital, norepinephrine was at 12 micrograms a minute. After initiating transport, when the blood pressure was noted at, I keep them in my chart, whether I think they're accurate or not, personally. When her blood pressure was noted to be 136 over 100, a few minutes before that, around the 48-minute mark, is when one of our paramedics started an IV, and we started an epinephrine drip as well, because her pressures were soft still. So the last known blood pressure we had with the epinephrine or the norepi running was 60 over 32 at 12 micrograms a minute. We started a second IV and then started epinephrine as well. So we had an epi drip and a norepi drip running. I generally start my epi drips. I know therapeutically around 8 micrograms a minute, 6 to 8 is where I get kind of a therapeutic response for most of these patients. So I just started off there to see where it was at. Our blood pressure was a 136 over 100, and then we checked manually a couple minutes after that, and it was 72 over 42. So questioning the accuracy of our 136 over 100, we checked manually, and it was still soft, right? So at that point, it was just kind of, a peri-arrest management of this patient on the way to the hospital. And it was only about a 10-minute transport from where we got to Peace Health Southwest. And at that point, once we had an airway established, and the pressors running, it was pretty manageable, and she never rearrested on us on our way into the hospital. So I believe, yeah, I think that was the complication of this were purely around the airway management that we had. And I tried out like 4 different things before I was able to actually get a good airway on her. I think that's everything I got.
Thank you. It's pretty a lot done in a short period of time. Dr. Monk, do you have anything that you have clarification or thoughts for teaching points?
Nothing to add. Nothing to add.
So I had a couple just listening to this. So especially with that delay in transporting agency's arrival, was there any communication about what you guys should bring, particularly the Craig kit?
There was no communication prior to that. I think generally, they have, the fire department always has their kits. The second unit will bring their kits in, and then we brought ours up anyway. So we had, minus the Crike kit, we had 3 full sets of gear on scene. For most routine cardiac arrest, it'd be managed just with that. So there was no communication about bringing the Crike kit in as well.
And then is there only one Craig kit available, I guess is my next question. Because it seems like it would have been, especially hearing you say that you had your partner go back and get the Craig kit. Is there only one Craig kit available?
I'm not sure, actually. I know we carry it in its own little black package that we keep in the ambulance. I'm not sure for the fire department side where theirs is at and how that works.
Is there anybody on BFD side that can speak to that question? Or if Mark or Dr. Mock knows that already? It's just some thoughts I had about.
Yeah.
Go ahead.
Ty Broman has his hand up. Ty, you want?
Hey, can you guys hear me?
Yes.
Yeah, the fire department in our airway bags, we do carry a Craig kit, a single Craig kit in each airway bag that we have at VFD.
And then DJ, I assume that you grabbing a Craig kit, no one said that we already have it out available.
Yeah, it was not.
So-
It was not an option. I think that's why I elected to do the 6.5 ET tube at first. I think I asked for a Craig kit, and then there wasn't one. I'm not 100% sure
Okay.
though. Yeah.
Okay. And then I know that we don't always document every component of these cases. What was the troubleshooting done to alleviate this obstructed tracheostomy? Was that communicated just not in the in your documentation?
Probably. Yeah. I didn't look at the narrative.
No, I was just asking, did they already try troubleshooting the trach besides
Oh
trying
yeah,
to
I
replace it?
yeah, sorry. I think they did try to place the old Shiley back in, and we're having difficulty with that. So, which makes sense given the collapsed tracheal rings. So yeah, it seemed like they had attempted to, and it was not working, and that's when they elected to use the eye gel. Yeah.
So the
I think
feedback
there might have
had
been, I
is-
think there,
okay.
honestly, I think there might have even been an innovation attempt. I'm not, I think that there might have been, but this was back in October, so I'm not sure if I remember.
How were they ventilating how was the ventilation of I guess this doesn't matter, how was the ventilation of the patient when she went into cardiac arrest? Where was the ventilation occurring?
Yeah, so we were in like basically the door to her apartment. We were essentially in the front door. So there was not a lot of space
Were
in the apartment in general.
ventilating from the mouth or ventilating the stoma?
Oh, from the mouth, correct.
And how was ventilating the mouth?
It was not, I mean, it wasn't working.
Okay. And so
Yeah.
was there air coming from the stoma, or was there someone occluding the stoma while they were ventilating from the mouth?
Someone was occluding their hand over the stoma while they were
Okay.
trying to ventilate, correct?
And the reason why I asked that for the others that are on this, listening to this lecture, is that if the patient had a laryngectomy, ventilating from the mouth would be ineffective. And if they do have a patent airway down to their lungs, if you're going to ventilate from the mouth, you have to cover the stoma. Otherwise, you're going to lose a lot of your effort through the stoma.
Yeah,
Um,
agreed. No, I would just
Yeah.
say this is really strong work managing this airway. But yeah, if in general, the best way to ventilate a patient with the stoma is through the stoma. Just go downstream and get from the stoma into the lungs. You can start with a bag over that, but in general, getting a tube into the stoma is what needs to happen.
In the emergency room, she was found to be in torsades with a pulse. They cardioverted her at 200 joules. They went to sinus rhythm. They treated her with 2 grams of mag. Her labs are notable for acidosis. Her pH was 6.9. Her PCO2, kind of think of it as like end-tidal CO2, was 63. And her bicarbonate, which also suggests her acidosis, was 15. And she was in acute renal failure, but she was not hyperkalemic. Imaging of her head and her soft tissue neck showed extensive neoplasm affecting the base of her right tongue, extending through the oropharynx and larynx. And then as for the hospital course, her tracheostomy was well established. It was placed in 2021, and that she was recently coming to our emergency room and to her ENT with complaints of neck swelling and tracheostomy complaints. She said that she was coughing up food. They scoped her 2 weeks prior to her cardiac arrest in the ENT clinic and noted that her mass was enlarging and that she was having some issues with her tracheostomy. On hospital day 3, her MRI of her brain showed severe global hypoxic injury, as she wasn't improving despite her supportive care, and her family decided to withdraw care. She passed away on hospital 10. And then I put underneath in the blue here what her ENT fiber optic scope showed just 11 days prior. So she was noted to have nasal cavity, nasopharynx, oropharynx, base of tongue, epiglottis, endolarynx, piriform sinus abnormalities thought to be from her recurrence of her cancer, and that it was having significant burden to her supraglottis and her larynx. They were unable to visualize the vocal cords due to how edematous she was, as well as degree noted thought to be related to her cancer, which they didn't mention. So sounds like to you guys, and I don't know if she quite understood that that was why she was having those problems. With her complaint that she was coughing up food, there's a concern, especially with her past medical history, to have a fistula, esophageal pharyngeal fistula, as well as this cancer ongoing. It could have blocked her passage into her trachea at where the tracheostomy was placed. It also could cause the tracheostomy to not be seated properly, increasing the odds for displacement. So I'm not sure if any of those or all of those played into her presentation. And then I think that I think it's worth mentioning that, you know, as DJ mentioned, this was not a typical cricothyrotomy. And I think that, you know, it's not exactly, I'm not advocating that we cut people's tracheostomies all the time, but I do think that thinking outside the box, especially in this patient's presentation, was a difference between getting Ross back and pronouncing this patient without ever achieving Ross. So I think thinking out of the box was really helpful. And I had one of the ER docs come up and ask, is that part of their protocols or their scope of practice? And I think that I would strongly support the situation. This is not a typical presentation of a patient needing a surgical airway. And I don't think that there was anything I would be concerned about. I don't know if, what's your thoughts, Dr. Ma?
No, I think this is the right thing for the patient, and I appreciate all the thought that went into it and the decision making in the moment.
Absolutely. And I thought it'd be another, you know, picture of the landmarks for cricothyrotomy, finding thyroid cartilage, stabilizing that, knowing that at the end of your thyroid cartilage is going to be your cricothyroid membrane. But I wanted to, I didn't put a slide because so I wanted to talk briefly about managing a tracheostomy that isn't working. So, you know, we have our dopes, dislodgement, oh man, I should have wrote those down. What's O? Is anybody obstruction? Yeah, obstruction. Of course, I didn't write it down. Now I'm running an issue to remember them. Anybody want to put it in the chat about dopes? But that's just like your typical ET tube malfunction algorithm to go through, but it's a little different when it comes to tracheostomy malfunction. So I found an algorithm called the green algorithm, and as far as I can tell, it looks like it's from the UK, but I thought that it had some really good points to help remind us how to troubleshoot a tracheostomy that's not working as planned. So, you know, assessing to see if it really is a tracheostomy issue. So assessing airway patency and signs of life, looking, listening, feeling over the mouth of the tracheostomy, and if they're breathing, providing oxygen via the mouth or stoma. And if they're not breathing, obviously, and they will not have a pulse for very much longer, starting CPR. And that they recommend, if you're going to bag the stoma, that you either get the adapter to bag directly over the tracheostomy, or to use a PDVM to go over the stoma side. And then if the tracheostomy is new, meaning less than 7 days, you're not blindly placing any tracheostomy, you're not replacing any tracheostomies, as the risk for false passage is high, obscuring your anatomy and making it much more difficult airway. The points that they had also mentioned was that end-tidal CO2 is super helpful, as it helps to identify early if the tracheostomy is actually patent or not, before the time it takes to determine that it's not working properly, either by pulse ox or the patient not responding. So get an end-tidal as quickly as you can in conjunction with troubleshooting the tracheostomy. If it's apparent that this tracheostomy is the issue, they recommend removing all external adjuncts, so inner cannula, any type of suction connected, or the speaking valve, removing that and passing a suction catheter first. So attempting to pass it through the trachea and just past it, past the length of the Shiley or the tracheostomy, and then suctioning below it and through it, trying to remove any obstructions. If a cuff is present, deflating the cuff to see if you are able to ventilate. If you are able to ventilate when the cuff is deflated, then you have some type of obstruction of the tracheostomy, or it's displaced. If you're ventilating a patient with an uncuffed tracheostomy, you're going to have a difficulty because it's not going, you need a cuffed tube to be able to ventilate. So, if you remember that in these situations, fantastic. But if you don't, you'll end up having an air leak. And then lastly, if you pass the suction catheter and that is the issue, you can't fix that. You deflate the cuff and you know that there's ventilation, but it's just not coming. It's not working through the tracheostomy. Then your third would be to remove the tracheostomy. Can you oxygenate via the stoma? Remember, do not place any blind tracheostomies if the tract is new, less than a week old, and you're going to ventilate through. If you hopefully remove the tracheostomy, insert a new one, you'll be able to ventilate through that. If not, then you're really moving towards intubation or CPR, and you can trial an oral intubation, or you can make a second emergency stoma intubation with a 6.0 cuff tube. Although they recommend size smaller than the tracheostomy that was placed. Hopefully that makes sense, as I don't have any words to explain that, and for visual learners that might be difficult. I can, when I get back on the second, I will update my presentation and send that out. Does anyone have any questions about that? Hearing nothing, I assume that there isn't any. So I pulled up the Southwest Region Protocol surgical airway regarding cricothyrotomies, and remember, this is of adult patients, not to be performed on pediatric patients. Life-threatening upper airway obstruction, where other measures to establish an airway and ventilation have failed and endotracheal intubation is not feasible. Identify the cricothyroid membrane, make a small horizontal incision, insert your finger through the cricothyroid membrane, insert a bougie into the trachea, place the appropriate trach tube or bougie that's been cut down into the trachea, and confirm with end tidal breath sounds. But remembering end tidal is going to be mandatory throughout the rest of the care for that patient. And then for pediatrics under 12, needle jet cricothyrotomy. So thank you so much. You guys can hear me okay?
Yes.
Okay. Thank you so much, DJ, for being able to be present to give us our pre-hospital perspective, and also really demonstrating some really tough cases that I thought, really well done. I've been holding on to this trach cric patient as a possibility for case reviews for months now. So peds trauma, peri or cardiac arrest goes to the closest hospital. No epi in trauma arrest, and resuscitation starts when you make contact, that should be really en route with transporting the patient for the resuscitation, unless there's complications with doing that and you have to pull over. Communication with the family, especially medically literate family members, is really key for high stress situations, as demonstrated with the cerebral palsy kid. Recognizing the methods to improve your odds of success, and recognizing and preparing by getting extra hands early, and then really MacGyvering this tracheostomy that got dislodged and likely occluded by her cancer. And this is a picture of the Amazon and the Amazon River, where I am at, getting eaten by mosquitoes. Hopefully I won't bring back malaria or yellow fever. But anyways, anyone have any questions? Thank you so much for your time. Sorry when we went over.
No, and I just wanted to say thanks to Dr. Gadbois to hiking to a place with internet service in the middle of the Amazon to do this. and for all the work you put into preparing this. DJ, thanks very much for being on the call, and one, for all the work you do, two, for putting forth your decision making in the moment, and giving other people a chance to learn from these tough cases. I think that does a lot to improve the care we provide as a system. The last thing I'll say is I put a link in the chat, and I'll share my screen. We really care about the feedback that we get on this. We are trying to put out the best educational product that we possibly can, and we want to keep continually improving it. So we really value your feedback, and we'll use that to make these sessions better in the future. So please take just a minute. It's a 2-question survey to give us feedback on how we can improve.
Thank you. Absolutely.
Thank you both for letting me speak and talk about these calls too. I appreciate it.
No, we really appreciate it, and I think it's much better to, whenever possible, to hear these cases from the people who are doing the work and taking care of the patients in the moment.
All right. You guys have a great day.
Thanks, Jackie.
Bye.